Welcome to Module 1, Introducing Classification Systems and the Communication Function Classification System, or the CFCS. After viewing this module, you will be able to describe classification systems and how they can be used clinically in administration and in research, differentiate a classification system from an outcome measure, describe the methods used to develop the Communication Function Classification System, or the CFCS, and explain research conducted to validate the CFCS for use with all children in addition to those with cerebral palsy. The primary purpose of a classification system is to discriminate among variations in the expression or stage of progression of a health condition. It is important that those in fields like speech-language pathology are able to make such discriminations because often children with the same health condition or diagnosis vary a lot in their functional abilities. For example, one child with phonological delay may use a few phonological processes and be relatively intelligible and able to communicate with most listeners, while another may use multiple processes, be highly unintelligible, and struggle to communicate even with familiar listeners. Without a way to discriminate among variations of this impairment, it is difficult for clinicians to accurately communicate clinical impressions and prognosticate. For programs, it is difficult to interpret outcome data and make decisions about services and resource allocation. In research, it can be hard to know which clinical populations to generalize findings to. Traditionally, speech-language pathologists have used terms such as mild, moderate, and severe to describe a child's communication impairment. This is problematic for four main reasons. First, these terms are value-laden and imply something is wrong with the child, and tell nothing about what the child can do. Parents may find these terms upsetting or unhelpful. Second, these terms are imprecise and are rarely defined or used systematically. Third, these terms aren't used reliably. What one clinician labels as mild, another might label as moderate or severe. And fourth, there is no evidence that these terms are valid. That is, that they are different from each other and associated with different outcomes. Classification systems promote consistency in terminology and provide a means for communication about a child's abilities and function. They also help clinicians and researchers to determine whether evidence about a method of assessment or treatment or about prognosis is relevant to a specific child. Classification tools are not tests, outcome measures, or diagnostic tools and should not be used in place of formal speech-language assessment measures. Classification systems are simply used to describe levels of functioning, and they focus on ability and performance, or people's usual activity in everyday settings. They are to be used together with other assessment tools and measures to describe function. Clinically, classification tools can be used to communicate with families. Instead of taking the traditional deficits approach to describing children's impairments, clinicians can describe children's functional abilities. For many classification tools, we now have associated quantitative data from outcome measurement tools, which allows us to answer parents' big picture questions about what will happen in terms of their child's development. Classification tools can also promote parent involvement in decision-making. They often involve simple word pictures that parents can use to identify their own child's functioning, and there is good evidence that parents can classify reliably. In administration, managers may use classification data to understand the functional abilities of the populations they serve. Data from classification systems can also be used to plan service delivery and explore treatment and management options by functional level. Researchers have used classification systems to study the relationship between functional levels and other abilities such as children's communicative participation skills, and also to describe improvements in children's function. This does not mean classification systems were used as outcome measures, but rather as tools to describe whether children's functional skills changed during a set period of time.
In the field of healthcare and in the areas of our interest, classification systems are ways of categorizing people according to some characteristic in which we are interested. Classification systems with which I'm familiar have been developed and explored in the field of childhood disability, and they are meant to give us a more precise and clearer account of different levels of functioning than we've traditionally had. I often decry the fact that we have talked about mild, moderate, and severe when we refer to impairments, for example, in mobility or communication. And there are problems with those words, first of all, because they're not defined, and we don't know if people use them consistently. We don't even know if we ourselves use them consistently from time to time. And because they are relative to one another. So, for example, if I tell you your problem is mild, I'm really saying you should stop complaining because it could be a lot worse. And that may be true in terms of the 100 people who have this condition, but for you, that's not very helpful. When we have valid and reliable classification systems, we can be much more precise about what we're talking about, because we have, in effect, pattern recognition pictures. They may be literally pictures, they may be metaphorically pictures in terms of word pictures, which allow us to relate what we're seeing with this particular person to the pictures themselves. The way in which people use them is increasingly varied as the systems become more readily available, more popular. My interest in classification systems goes back well over 20 years to the gross motor function classification system, which we developed to get past the mild, moderate, and severe idea. And what we were able to do, first of all, was to develop a system which is reliable, that is to say people use it consistently, including parents as well as clinicians, and that it's valid, that is to say that the different levels are in fact demonstrably functionally different from one another. Having developed the system, people now can look at, in this example, cerebral palsy in a whole variety of ways that we couldn't do before. So one example I like to cite is that we know that people with cerebral palsy are at risk of having problems with hip dislocation. And before we had the classification system, we worried about everybody. We probably x-rayed or should have x-rayed everybody. Well, it turns out from some very good population-based data from Sweden and from Australia that the risk of having problems with hip dislocation is a direct line from level 1 function, which is very good function, to level 5 function, which is most limited. So, for example, people in level 1 have 0% of having a hip problem. People in level 2 about 15%, in level 3 about 40%, in level 4 about 75%, and in level 5 about 95%. So we now have a way of stratifying by classification who we should be concerned about in what ways. Families often want to know, how bad is it? Will my child walk or talk, or whatever the question is. I think what we need to do, however, is recognize that we have to wait for families to ask that question and not tell them how clever we are by telling them things they haven't yet indicated a readiness to hear. When they're ready, we can answer those questions, like your child is functioning at level X, and when they say, what does that mean, we are increasingly able to give a prognosis about that particular dimension of function based upon the classification system and people's experience with it.
The Communication Function Classification System, or the CFCS, is a classification tool specific to children's communication. It was developed using the World Health Organization's ICF framework with a focus on activity and participation, or a child's functional communication abilities, not how their body structures or functions are impaired. Another aim was to support clinicians and researchers in reliably describing children's communicative function. The CFCS includes 5 strengths-focused levels of communicative function that are used to describe children's skills. Children in Level 1 function best in terms of their communication, and children in Level 5 function least well. These are used instead of traditional terms that are grounded in impairment such as mild, moderate, and severe, which are problematic for 3 reasons. First, they have never been shown to be used reliably between clinicians, so what one clinician calls mild, another might call moderate. Second, they are value judgments that focus on a child's impairments and what is wrong. And third, they tell us nothing about what the child is able to do. The CFCS was developed in 4 phases. In Phase 1, the CFCS was drafted by a development team that included researchers, clinicians, parents, and people with cerebral palsy. In Phase 2, nominal group studies were run to revise the draft CFCS based on stakeholder feedback. In Phase 3, 2 Delphi consensus studies were run to establish agreement among stakeholders about the content and format of the CFCS and to validate the CFCS. And in Phase 4, inter-rater and test-retest reliability studies were conducted with professionals and parents. 11 individuals participated in Phase 1 to develop a draft of the CFCS. The CFCS was originally developed for individuals with cerebral palsy, so those 11 participants represented 8 groups who had experience with CP and communication. They were an adult with cerebral palsy, a parent of a child with CP, educators, rehabilitation and medical professionals, and researchers. The first draft of the CFCS was developed based on reviews of the literature on functional communication and participants' experiences of communication in real-life situations. To develop the draft, ideas were shared through a series of 5 group conference calls and subsequent email correspondence. Discussions and revisions were shared through additional phone calls and emails. The initial draft included 6 variables the team viewed as important parts of functional communication: sender skills, receiver skills, pace of communication, degree of familiarity with the communication partner, age appropriateness, and use of augmentative and alternative communication. The initial development phase ended when the group was satisfied with the draft. In Phase 2, a nominal group process was used to establish a consensus opinion among relevant stakeholders. The nominal group included 27 participants from Canada and the US and included adults with cerebral palsy, educators, neurologists, physio and occupational therapists and speech-language pathologists, and researchers. 4 nominal groups were conducted to establish consensus among stakeholders about the content of the CFCS and to demonstrate content validity. Each group included representation from all stakeholder groups. Each group met for up to 4 hours to discuss the content of the CFCS, generate answers to open-ended questions, and vote on suggestions to determine consensus. The process included progressive feedback. This means each group suggested changes that built on the previous group's revisions. Changes that received a majority vote from the group were incorporated into the next revision. By the 4th group, consensus had emerged about the concepts included in the CFCS. This means stakeholders felt the CFCS captured a large range of communication abilities and that the wording was understandable to those with differing perspectives. In Phase 3, 112 stakeholders from several different countries participated in 2 rounds of Delphi surveys to evaluate the clarity and usefulness of the CFCS. In Round 1, the group made ratings on 36 questions about the CFCS, and the criterion of 80% agreement was reached for 35 of the 36 questions. 1 question about being able to differentiate between CFCS levels did not reach agreement, and revisions were made to that 1 question. In Round 2, the group reviewed the revised CFCS and the 80% criterion for agreement was reached. In the last phase, the CFCS was tested for inter-rater and test-retest reliability. 61 professionals and 68 family members supported this phase. Inter-rater reliability was tested by having 2 professionals and 1 parent classify a child's communicative function, and inter-rater reliability between 2 professionals was moderate. It was less reliable between parents and professionals. Test-retest reliability was evaluated by having professionals classify a child's communication 2 weeks apart, and reliability was considered statistically strong. The CFCS was originally developed and validated for use with children with cerebral palsy, and in 2017 it was validated for use with preschoolers with a range of speech and language impairments outside of those with cerebral palsy. The validation was done using an existing dataset that included data for 77 preschoolers. The children included in the dataset had a mean age of 2 years, 7 months, and 50 were male. The study explored repeated measurements using two tools, the CFCS and the Focus on the Outcomes of Communication Under 6, or the FOCUS. The FOCUS is a parent report measure of children's communicative participation, and it is similar to the CFCS because both are used to describe children's functional communication skills. In the validation study, both parents and speech-language pathologists completed the FOCUS at 3 assessment points: at initial assessment, at the start of a treatment block, and at the end of a treatment block. And functional communication was classified by speech-language pathologists using the CFCS at the initial assessment. To establish construct validity, the relationships between children's FOCUS scores and CFCS classifications at the point of first assessment were explored. To establish predictive validity, the relationship between CFCS classification at the point of first assessment and FOCUS scores at the start and end of a treatment block were explored. The relationship between CFCS classifications and FOCUS change scores was also explored. All this was done separately for both parents and speech-language pathologists' ratings of children's communicative participation on the FOCUS. Strong evidence of construct validity was seen in the significant negative correlations between CFCS classifications and both parent and speech-language pathologists' reported FOCUS scores at the initial assessment. This means that children in higher levels of communicative function were rated as having higher communicative participation skills on the FOCUS. For example, children classified as CFCS Level 1 tended to have higher FOCUS scores than children classified as CFCS Level 3. Evidence of predictive validity was also seen in similar negative correlations between CFCS classifications made at the initial assessment and both parent and speech-language pathologists' reported FOCUS scores at the 2 later assessment points. There were no significant correlations between CFCS classifications and FOCUS change scores, but this was not unexpected because children in all CFCS levels showed improvements in their communicative participation skills over time, and because the FOCUS was designed to measure change equally for children at all levels of communicative function. Taken together, the results of this study suggest the CFCS is valid for use with preschoolers with a range of communication impairments outside of those with cerebral palsy.
Classification systems are essentially measures and need to be developed and field tested with that reality in mind. This means, for example, that we need to know that if several of us look at the same situation, we classify it in the same way. That is to say that we are reliable from one person to another. We are consistent. Because if I say X and you say Y and somebody else says Z, we can't all be right. We can all be wrong, but we can't all be right. And we need to know that if one of us says X, the likelihood is that the others of us are going to say X as well. That's a function both of the clarity of the system and how well people are trained to use it. Then we have to know that the differences between level X and level X plus 1 and level X minus 1 are meaningfully different. So our classification systems for gross motor function and for manual ability and for communication and for autism have 5 levels. Why 5? Empirical. We started off when we developed our motor system 20 years ago with 4 levels, and when we did some field testing, the therapists we worked with and who did the field testing with us said you need to break up the lowest functioning level into 2. So we did, and we ended up with 5. And then when the other systems, which are analogs of this gross motor function classification system, when they came along with the manual ability classification system and the communication function classification system and the autism function classification system came along, 5 seemed a reasonable number. People have said to us, well, you need 6, and we say, no problem, do it, but also show that the 6 are useful and more useful than the 5, that they are reliable, and that there's a valid distinction between the levels so that there's some meaning to them. Well, I like to talk about autism as an example. We have traditionally talked about high functioning and low functioning autism. and nobody seems to know what they mean by this. If we have a classification system, and we in fact do, we've created one here at McMaster, if we have a classification system that allows us to talk about children in levels 1, 2, 3, 4, and 5, we now can look at the characteristics of those children. We can look at the interventions they're receiving. We can look at the impact of a particular intervention on children in different levels, and so on. We've never been able to do that before. And that has bedeviled the whole of our field, because we've done interventions, but we don't know the characteristics of the people receiving the intervention. And so we're not sure who's benefiting in what way, for what purpose. With the classification systems, we can begin to do that. The classification systems are an improvement on what we have already. They're not the end of the story. There's lots more work to be done. But that's one way in which a huge amount of work in cerebral palsy has been influenced by and informed by the classification systems. And we're very proud of the fact that it's very, very rare to find a paper about cerebral palsy and gross motor function that does not use the gross motor function classification system. It's been cited in the literature well over 6,000 times, and everybody in the world of cerebral palsy knows it and uses it. And that's as it should be. And by the way, it's free, so I can brag about it without getting any money. Well, partly it's because we put a lot of effort into promoting it, again for free. Secondly, because I think people saw the value of it, and it became increasingly popular and increasingly well used. The field of speech-language pathology in children is still, I think, in an early phase of adopting the communication function classification system. But the more people use it, and the more this becomes a common way of talking about children's function, the more other people will use it. And there's an opportunity for everybody in the field to be looking at it, using it, applying it, sharing it with families when they ask, and so on. One of the interesting ways in which classifications help people is related to an email I got literally 4 days ago from an occupational therapist who wrote to me about a child with a Hemi syndrome who has very good day-to-day activity in her more functional limb and quite limited ability in her impaired limb. And this therapist was asking me how to classify this children with respect to the manual ability classification system. So I wrote back and I said, is this child independent in day-to-day activities? And the answer was yes. And I said, well, then you'd classify the child in max level 1, most functional. But if you're going to do a detailed assessment of both limbs, you may find that there's a big difference between the capacity of the more impaired limb and the typically functioning limb. And that's the distinction. We want to know ultimately what can you do in day-to-day living even though you have an impairment. And this therapist, I think, found this extremely helpful.
In summary, classification systems are tools that focus on children's strengths and current functioning and provide a reliable alternative to traditional terms like mild, moderate, and severe. Classifications have multiple uses in clinical practice, for research, and in administration. The communication function classification system was developed using rigorous research methods and is a valid and reliable tool. And the CFCS is valid for use with preschoolers with a range of communication impairments outside of those with cerebral palsy.